Hi guys, I hope you had an awesome weekend. I just want to review quickly some of the information in chapters 1 through 5 with you to make sure that you were able to pick up on all of the key points that we didn't have a chance to cover in class. And I picked up this cool little pen at the conference that I was at this weekend that allows me to draw right on my computer screen. I don't have to do it with my finger, which makes me pretty happy. All right, so we're going to start off with part 1, and I'm going directly off of your outcomes to help make your studying a little bit easier. But part 1 pretty much covers chapters 1, 2, and 3 in your book. So we talked about mental health and mental illness, and mental health being, or mental wellness being, the successful adaptation to stressors from the internal or external environment. And that means that your thoughts, feelings, and behaviors are congruent with local and cultural norms and age appropriate as well. And I was thinking of a really good example of this today, watching my kids do some things that were silly and thinking like there's no way if these guys were adults or even teenagers, really like older teenagers, that anyone in society would think that this was normal. But because they're younger, you know, they can kind of still play and have, you know, magical thinking. And so they're mentally well. Magical thinking is normal for a child, but we would consider that mental illness in many adults, right? So with mental health, there's no functional impairment. And so, you know, when we're assessing somebody, there's no impairment. Oh, I guess this isn't going to work all that well. Oh, well, okay. It sounded really good when I got it. That's supposed to say impairment. Anyway, when we're assessing somebody, whether they have anxiety, depression, if they have schizophrenia or something and they're on medications, or if we're just looking at their overall, you know, mental wellness, we look at their ability to manage their everyday stressors, basically, and adapt to those. And so they either adapt or they have maladaptive behaviors, and that determines how we gauge them as well or ill. If they're mentally ill, then they're unable to adapt. The general population then doesn't really understand their behavior because they have an interference in daily functioning that we would consider to be normal for that person, right? So then it kind of skips back to chapter 1 and it says examine fight or flight. So the fight or flight deals with that general adaptation syndrome, which is what Hans Selye kind of coined that phrase. But the fight or flight syndrome was when, you know, you're exposed to stress, your body kicks out that norepinephrine and epinephrine. And I'll try to write norepi here. And in response to that, we have all of these vasoconstriction, and we have activation of the beta receptors in the heart and the lungs. So the heart beats faster and it beats harder, so our cardiac output is increased, and we can move more oxygen to our cells, and we can get rid of waste products faster. And we also then stimulate the release of insulin and glucagon so that we have more glucose available for use by our muscles. And so really what we're doing is increasing the delivery of food and oxygen to our muscles so that they can either fight or run, and we're removing the waste products faster so that you can maintain your stamina a little bit longer and you don't get, like, you know, that runner's cramp. So that's kind of the purpose of that. It's supposed to be very adaptive, meaning that it's supposed to keep you alive, but when it becomes chronic, it becomes a maladaptive thing. And so for each one of us, depending on how much stress we have in our lives, our response to stress is going to vary. So remember that there's 3 stages there's the alarm reaction stage where there's just the physiologic response of the epinephrine, norepinephrine. And then there's the stage of resistance where the body either adapts or develops a chronic problem. And then that stage of exhaustion, and we talked about that, like, you know, when you have like back-to-back exams and papers and you're working and you're studying and you're not sleeping, you get sick. So basically you burn up all of your coping mechanisms to the extent where you're just exhausted, and eventually your body gets overwhelmed and you get sick. And in worst case scenarios, you can actually die from that. Okay, so sustained stress responses cause long-term problems in people, and it can cause, you know, hypertension, it can cause heart disease, it can cause atherosclerotic cardiovascular disease, you know, hyperlipidemia, elevated triglycerides in general. It can cause, you know, diabetes even. It causes so many problems to have chronic stress on the body. Okay, so we talked about how you manage stress, right? And so really our goal again is those adaptive coping strategies. You want to be aware of the problem, try to relax, and then use tools that work for you. So whether it's meditation, whether it's communication with somebody who is a caring person, not a stressful person to communicate with. You know, develop your problem-solving skills so that little things don't stress you out anymore. You know, pet therapy, we talked about music. But if you're not able to manage that stress, it's going to become maladaptive, and you're going to instead turn to things like isolation, self-medication, and then even some of those maladaptive ego defense mechanisms like, you know, denial. Right, so those would all be bad. So that excessive stress leads to illness. So the 4 levels of anxiety, flipping back to chapter 2, are a mild, moderate, severe, and panic. And in panic, there's also kind of that subclass of severe terror. So mild is just some tension. Again, remember that's kind of like good stress for a lot of us. That's like procrastination. It prepares people for action. It enhances your senses, your motivation, your perceptual field, your awareness, and enhances learning. Right? Now, with mild anxiety, it also talks about the ways that you mitigate that stress, right? And so the coping mechanisms that you might use some ego defense mechanisms. You know, those are used for mild to moderate anxiety, but most people just for mild, like low-level anxiety will have the coping mechanisms that are talked about on page 17. So they'll sleep, they'll yawn, eat, drink, exercise, daydream, smoke, laugh or cry, swear, pace, bite their nails, right? And I can always tell when my anxiety levels, like if I'm stressed out, my nails look much worse, and I don't even realize I'm doing it. Foot swinging, finger tapping, so just kind of that fidgety, you know, restless, fidgety kind of thing. And then talking. So some people just talk more. So somebody with mild anxiety is just going to seem a little restless. And again, that coping is unique to each one of us, but that's, you know, kind of the more mild. Moderate anxiety is increased anxiety with a decreased perceptual field. They become a little less aware of their environment. They have a harder time concentrating and might start to need some assistance with problem solving. And you start to see, you know, increased muscle tension. They get a little restless. And these people, you know, just seem like when you look at them, they look tense, whereas the mild person just looks like fidgety, right? So mild anxiety, they're fidgety, and the moderate anxiety, they look like really restless and tense. Okay, severe anxiety, again, greatly narrowed perceptual fields. They can only see one detail. They can only focus on one thing, which when we talked about this is really important when you're trying to give instructions, because if you say like, you know, okay, I just want you to sit down and take 10 deep breaths and count backwards from 20, you know, they're still focusing on the word sit, right? So you have to give them just single word, you know, commands, or very short, concise, simple instructions, and just really remain calm and focused when you're talking to them. Okay, they're going to start exhibiting physical symptoms that actually are concerning and might bring them into the ER even. Headache, palpitations, so that's where they can feel like fluttering in their chest, insomnia, so they can't sleep, and then add to that the emotional piece where they start to feel confused, dread, or even horror, and that really, you know, starts to set them over the edge, because the more afraid they are of whatever is causing the anxiety, and then these physical manifestations get scary, that kind of makes their anxiety spiral out of control. Okay. And then panic. And so in the panic mode, they can't focus at all. Sometimes they can't hear you. Sometimes they can't see you. They have misperceptions and a loss of contact with reality. So sometimes, I mean, this is like truly psychosis. Like, put the P's together, panic and psychosis, put those P's together. They have lost contact with reality. So they no longer are seeing things the way that they truly are, and they might actually have hallucinations or delusions. The behavior becomes extreme, wild or desperate, total withdrawal. They might become severely physically aggressive or totally catatonic in this true panic. And then they might experience like just severe terror, and then prolonged panic can cause such physical and emotional exhaustion that it can actually be life-threatening. Like, people can die from like terror or prolonged panic. So just things to keep in mind, you know, like mild is good, moderate, you know, starts to become problematic. Severe, we really need to intervene and help them mediate that. And once it gets to the panic stage, you know, pretty much all we have is like, you know, isolation and forced medication to get them to calm down in true panic. Okay, and one of the things that isn't really mentioned in there, those the carpal pedal spasms. So when patients hyperventilate, they'll get tingling around their nose and mouth from a hypocarbia, blowing off too much CO2, so they are becoming respiratory alkalotic. And then with that, they'll get spasms in all of the fine motors, and that includes the fingers and the toes. So their hands and feet will start to cramp up and spasm, and it's scary because they can't unlock them, and it's painful, and then their face is going numb. And you can imagine if you couldn't focus and rationalize, and all of that was happening to you on top of the chest pains, the palpitations, you can't breathe, and now, you know, your face is going numb and your hands and feet are spasming. That's terrifying. Right, and so that's where the nurse really needs to maintain his calm and say, you know, I'm with you, I'm right here, you're okay, look at me, and just, you know, like maintain that eye contact. You're going to be okay. Focus on my breathing, breathe with me. See if you can get them to do that. Now, if you watch that TV show Bull, one of the tricks that he employs is having people count non-sequentially. So like, you know, 5, 7, 3, 9, 11, 2, 6, like, because the brain wants to go sequentially, if you give people random order numbers, sometimes it will unlock the anxiety. I've heard of things like that before. Nurses aren't trained to do that kind of psychological intervention, but I don't know that it would be harmful. So those are our 4 levels of anxiety. Now, let's talk about those ego defense mechanisms. So I'm going to flip forward to chapter 3 for a second. Chapter 3 is talking about some of the theories of psychology. And so let's look at Freud. Freud talks about the id, which is your locus of instinct. So your kind of impulsive, irrational self that seeks out pleasure. Okay, so your id, a lot of times we try to suppress because that oftentimes isn't culturally acceptable. The ego is your rational self, and that focuses on reality. And the ego is what has to adapt and respond to those stressors. The ego's job, according to Freud, is to mediate the id, which is give me, give me, give me, and the superego, which is I am the perfect person in society. And so the superego says, that's the perfection principle. The superego says that I am a perfectly moral being and I adhere to all values within society. So the superego believes in ego rewards for good behavior, and the conscience then is a punishment for bad behavior. So the goal of the ego is to find a midline between what it is that we want and what it is that society wants from us, and to live somehow in harmony between those two things, right? So that's what he calls the ego, or a rational self. So let's go back now to 2 when we're talking about ego defense mechanisms. So how does the ego protect itself from just imploding every single time we're faced with stress? Because when you're faced with stress, your id wants to punch somebody in the face, and your superego wants to take the high road and say, oh, it's okay, don't worry about me, and be passive, right? So your id is like super aggressive, your superego is often very passive, and the ego just tries to be that like assertive person in the middle that says like, okay, there has to be a rational way to deal with this. So these are on pages 17 through 19 in your textbook. So all of these defense mechanisms are employed by the ego or used by your ego anytime there's a threat to biological or psychological integrity. All right, and as we talked about, some are more adaptive than others. So some you can use them both usually adaptively, but some are more maladaptive than others. And some you use consciously, and some are unconscious, but all of them, the goal is to protect the ego in an effort to relieve that mild to moderate anxiety. So you would never use these ego defense mechanisms in that severe to panic mode, because you can't think or process, you can't problem solve at all. So mild to moderate anxiety, that's the only time the ego uses these defense mechanisms. Sometimes, so again, they're self-protective usually to relieve stress. Sometimes they become maladaptive, and when that happens, there's a disintegration of the ego. And what that means is that it's these can be self-deceptive, meaning you think that you're doing something that's going to protect yourself, and really what happens is you're not forcing that. When you use these ego defense mechanisms, you're not forcing yourself to come face to face with reality. So you're not balancing the id and the superego. You're kind of letting one or the other win, and it throws off your balance, and then you're in this kind of conscience flux, ego-wise. So if you do a really good job, you're going to get the ego ideal reward of being like, hey, good job. You really did a good job of being assertive and talking that one through. And if you use a maladaptive response, your conscience is going to be like niggling at you like you didn't do the right thing, and it's going to be eating away at you, and you're going to feel icky about it afterwards. And that's a lot of times how you know that you used an ego defense mechanism, a lot of times without even recognizing it, because afterwards you're like, wow, that felt really awful. I wish I hadn't done that. Okay, so that's, that's your conscious kicking in and saying like your super ego is unhappy with you because you didn't live up to your perfect person that it thinks you could be. So some of the ones we talked about these in class, and they're so good. You guys did a great job thinking of some different opportunities here, but some of the ones that I think get used a lot: compensation, definitely; denial, absolutely; displacement, definitely. And we talked about displacement in terms of the nurse sometimes has anger displaced towards him or her from the patient because they don't feel comfortable being angry with the doctor. So we feel like a safer target, essentially. projection, again, like, you know, if you think that you're doing or feeling something that's unacceptable, and then you accuse somebody else of doing it because, you know, you would rather that it wasn't true about you. And so that's your super ego saying, like, you shouldn't think that way, you shouldn't feel that way, you shouldn't do that. And your id is saying, like, yeah, do it. And then your ego can't kind of figure it out between the two of them. And so instead it says, like the example in the book, like, oh, he's hitting on me, because you, like, think that somebody's cute, whatever. Rationalization. So rationalization, again, another one, like, I hear this a lot when we get patients in the ER that are using alcohol or drugs or whatever, and they're telling me about how stressful their life is, and so, you know, like, they have to use these drugs or alcohol, otherwise they would do something else that was even worse. Like, you know, oh, well, if I didn't drink, I was going to hurt myself. So again, they're rationalizing their behaviors by trying to make it acceptable because there's something worse that they could have done. Or, you know, like, a lot of people will say to me, like, oh, I only smoke pot, I don't do anything worse. You know, so again, rationalization, their ego's trying to make themselves feel better about what it is that they're doing, because they don't really feel like it's okay. Because if they really felt like it was okay, they wouldn't feel the need to rationalize that at all. They would just be like, oh yeah, hey, I smoke pot, you know. Reaction formation, again, you start to think that, you know, you don't like doing something, but you force yourself to do it to make somebody else happy usually, and so then you pretend that you like it. And this actually falls into play with a whole other host of psychological theories, but like, the volunteer who doesn't get paid at all is more likely to be dedicated to their job than the person who does the same job for minimum wage. Because if the volunteer is getting up at 4 o'clock in the morning to, let's say, you know, deliver newspapers or something, and they say, like, you know, oh, I'm doing this because I'm not getting anything from this other than just the pleasure of doing it. But the person who's getting minimum wage says, like, you know, this isn't worth it to me to get $7.75 or whatever minimum wage is these days. So with a reaction formation, the person would then say, like, you know, oh, then what pretty much the volunteer says, I'm doing this because I love doing this, rather than doing it because they receive something for it. But, you know, in your book, they also give you a lot of examples, like, you know, somebody who's going to nursing school doesn't really want to go to nursing school if their parents are making them. So, you know, instead they're like, yes, I love nursing school, I'm going to be the best nurse ever. But then they're never really going to be happy or fulfilled. So, you know, don't live somebody else's dreams for you. And there's all sorts of, you know, books and movies and stuff about reaction formation out there. And then repression we talked about as well, and I think repression's another really important one. And that's where you involuntarily block unpleasant feelings and experiences from your memory, right? So again, if there's some sort of emotionally traumatic event, rather than dealing with it, the ego just says, you know what, I'm just not even going to remember this, so I can't make sense of it. You know, I can't process it, so I'm just going to kind of wipe it out of my mind altogether. Different than suppression, where it's voluntary, where the person says, like, I don't want to think about that, and, like, you can try to talk to them and they actually remember it, but they refuse to talk about it. In repression, it's actually like the subconscious mind that says, nope, not going to happen. So ways that they bring out repressed information would be, you know, like deep hypnotherapy or deep psychotherapy, things like that, to try to pull those memories out. With suppression, you know, just talking to the person can actually bring out those memories or recall. So just make sure that you read through those ego defense mechanisms again. And then discussing the DSM-5 evaluation system. I'll talk about this in class. It's not on this exam, but basically there are you can't just like walk into an office and have somebody look at you and say, oh, I think you're depressed, and give you a diagnosis. There's actually medical things that you have to rule out first. So you have to rule out like, like hypothyroidism or, endocrine disorders, things like that first. And then from there, you would make sure that they meet a certain number of criteria of the diagnosis in order to actually have that diagnosis. So it's a manual, it's a diagnostic manual for providers to be able to provide psychiatric diagnoses for their mental health patients. Okay, so that is part 1. And notice that we haven't gotten to grief yet because that's in the next part. But that's part 1, so most of chapters 1, 2, and 3. Okay, so in part 1, which aren't clearly outlined in your outcomes, I just wanted to add on some other stuff that is technically in your reading and is going to be on your exam. So the first is grief and loss. Grief is a subjective state of emotional, physical, and social response to the loss of a valued entity. And we talked about the fact that it could be real, which means that somebody else could substantiate that loss. So it could be a person or a possession, or it could be a perceived loss, and that means it's unable to be shared. So that's a loss of feeling, or a loss of like status. And then there's an anticipated loss, which is the response prior to an event. And so you emotionally disengage from somebody who's dying in order to kind of blunt your grief or, decrease your pain. But that kind of backfires because then the person who's dying often feels rejected. So anticipated grief is often good for the griever and bad for the person who is dying. Any situation that creates change, including failure or a loss, can cause grief. And we talked about the fact that not all individuals experience each stage of grief or loss the same way. Okay, so they don't necessarily experience all the stages in order. Some go back and forth. Some even experience more than one stage at a time. Okay, and grief can last anywhere from weeks to years. It can't be hurried. You can't like rush it along. And guilt has been shown to lengthen the grief reaction. So if the person feels somehow responsible for the loss, or if the person feels like there was unfinished business, that can extend the grief. The stages of grief are on page 22 in your textbook. Denial. This didn't happen. No, that's not him, or that's not her. Anger, right? Why did you do this? And they might be angry at the person who died, or they might be angry at the person who they feel is responsible, or they might be angry at God, or they might just be angry in general at everything. Bargaining. Take me, not him. I'll go to church every Sunday if you just give him back to me. So there's a lot of this like pleading and bargaining and trying to almost like rationalize what happened. Depression, so this profound sadness over the loss, and then acceptance. And the way that you as a nurse can tell if acceptance has happened is that the grief has been successfully resolved. When the person can look back and accept both the positive and negative aspects of that relationship. So when somebody loses someone in that acute loss phase where they're experiencing the denial, the anger, the bargaining, the depression, a lot of times they look back and they only remember, the very positive things, or if they were very upset about the person, maybe they only remember the negative things. Once they reach the acceptance phase, they can remember that it wasn't perfect, but they can accept it for what it was. They can remember the good, they can remember the bad, they can accept it for what it was. And this is true also of relationships. So when a relationship is terminated, oftentimes if you're the person doing the terminating, you remember only the bad things. If you're the person who the relationship was terminated from, you may remember only the good things and, want to get back together. And then for both of you, once you have come to that acceptance phase and moved on, you can both look back at your relationship and recognize that there were good things and bad things. Okay, so that's acceptance. That's the acceptance phase. And that's really what we're looking for in nursing, is have they made it to that phase where they've kind of come to terms with what has happened. Okay. Bereavement overload is a concept that they talk about in your book as well, and that's where you just have so many losses in such a short time that the cumulative amount of grief just becomes overwhelming, and this can just cause such a severe amount of stress on people. It can cause all sorts of emotional and mental health problems. So grief responses become maladaptive, so we don't handle them well, when they either don't ever get resolved, or they just get like stuck and they don't progress. Okay, and usually when they get stuck, it's either in that denial or anger stage. So there's prolonged grief, where the person has this intense preoccupation with memories, even sometimes years and years after the loss. So for years, that person is intensely preoccupied with the loss. Okay. In delayed or inhibited grief, they just totally deny it. It didn't happen. Like every day that they wait for that person to come home from school or whatever, and they might develop severe anxiety related to that loss. And then in distorted grief, they get fixed in the anger stage. All right, so delayed grief, they're in denial. Distorted grief, they get very angry. Normal grieving behaviors are exaggerated, and then they might end up with a pathological depression. So they become like so angry that they actually end up with this pathological depression at the end. So on page 24 in your textbook, Figure 2-3 goes over the anxiety and grief responses and coping mechanisms. So again, good to review, good information, and definitely things that we look at. Okay, and then the last, I touched on this briefly, but I just want you to understand that there's, it's really important to understand the difference between somebody who's neurotic and somebody who's psychotic, because nursing care is very different between these two people. So we used to joke and say the neurotic person builds sandcastles in the sky, and the psychotic person actually like moves in. Okay, so and I was saying to you, like, the panic person is psychotic, like they're totally lost touch with reality. So in the severe anxiety phase, extended severe anxiety causes neuroses. So neuroses is usually excessive anxiety, and the person is trying to mitigate that. So we see the obsessive compulsive disorders, the phobias, sexual dysfunctions. But when you're neurotic, you're aware of what you're doing. So somebody with an obsessive compulsive disorder is fully aware of their disorder. Okay, they know that their behaviors are maladaptive, but they're unaware that there's a psychological cause. So what they can't identify is the anxiety behind it. They can't put those two together, and they feel very helpless to change it. So they just feel like the obsession and the compulsion are overwhelming to mitigate that stress. And they can't stop. Okay, so that is a very real thing, but otherwise they're with it. So this is just an anxiety response. So neurosis is an anxiety response. There's an N in anxiety. Neurosis deals with severe anxiety. Okay. No loss of contact with reality. Again, neuroses, no loss of contact with reality. Put those N's together. In true panic, we have psychosis. The person becomes psychotic. So put the P's together, okay? And with psychosis, there's a gross impairment in reality. So they have the delusions, the hallucinations, the disorganized speech, disorganized or catatonic behavior. And the problem with the psychotic person is that they are so panicked. Remember, they can't even focus on a single detail in the panic phase, that they're unaware of their behaviors. They're unaware that they're maladaptive. They're unaware of their psychological problems, and they have a total flight from reality. So they have kind of left what we would consider normal contact. And they are kind of out there. So they have moved into the sandcastle in the sky. Life is really good there. And the reason that they go there is to avoid having to deal with the issue. So they basically go from stress to a non-stressful place where they can be really happy. And so we see this with like schizophrenia and just delusional or disorders as well. Okay, so this is chapter 4, and chapter 4 I know is a monster, and so I'm sure you're saying to yourself, what is it that she actually wants me to know? Because the learning objectives obviously are very, very broad. So let's go through here for a second. So what is it that we're thinking about in terms of this book? We're thinking about psychology. Right? So when you're going through here and you're looking at this book, I want you to think about what are the parts, like when it says identify gross anatomical structures of the brain and their function, the only ones I'm going to ask you about are the ones that deal with psychology. So mood, right? So in the diencephalon, you have the thalamus that deals with some emotions and mood, but then you have the limbic system, and the limbic system is actually pretty big, but that consists of the emotional brain, and that's fear, anxiety, anger, aggression, love, joy, hope, sexuality, and social behavior. So, you can bet your bottom dollar that the limbic system would be an important structure to know, because we're dealing with psychobiology, and that is the part of the brain, the limbic system, that controls the emotional brain, or that part of our body that's so important. Okay, so what I did was I highlighted some stuff in my book, but then I also just went through and kind of like drew out where the limbic system was and the emotional brain, and kind of what was important about that area. Okay, the role of the neurotransmitters then in human behavior. So there's kind of a rehash of the autonomic nervous system, the sympathetic nervous system. So you should be familiar with acetylcholine. So acetylcholine is like the major neurotransmitter within the autonomic nervous system, and it's the one that affects all sympathetic and parasympathetic presynaptic nerve terminals, and then all of the postsynaptic nerve terminals on the parasympathetic side. So like when we talk about cholinergic drugs, we're talking about the actions of acetylcholine. When we're talking about anticholinergic drugs, we're talking about blocking acetylcholine. So that term should just be somewhat familiar to you from your LPN year. So read acetylcholine, page 55. Read norepinephrine, page 55, right? So again, norepinephrine, fight or flight, right? It is an alpha drug that causes vasoconstriction, it causes shunting of the blood, but then it also, is responsible for some stimulation as well. So norepinephrine is also then responsible for, in the central nervous system, mood, cognition, perception, locomotion, cardiovascular functioning, sleep, and arousal. So we know that norepinephrine is related, along with dopamine and serotonin, to depression and like mania and anxiety and schizophrenia. So, don't think of norepinephrine as just being like an alpha, like a vasoconstrictor. I want you really to read that section about norepinephrine, and then dopamine and serotonin. So the cholinergics, the acetylcholine, and then the monoamines, the norepinephrine, dopamine, serotonin, like really, those are wicked important, okay, because that's what like the meds that we're giving, that's what we're focusing on, right? You can look at the histamine too, right? So a lot of antihistamines are anticholinergics. So, again, looking at histamine, that's important. And GABA is another one that's pretty important. So those sections, really read those and look at those. So let's look for a second together. So what do I want you to know? Norepinephrine, if you don't have enough of it, you're going to get depressed. If you have too much of it, you're going to get manic, right? You're going to feel anxious, and you can even have schizophrenia. So if you just think about, like, during the fight or flight response, I have norepinephrine like pumping into my body. What happens to me? Like, I get like amped up and I get shaky, right? So that would go along with like anxiety and even like mania. Like, it just super stimulates your brain, and then it can even cause schizophrenia, right? Now, dopamine, very similar. If there's not enough of it, you get Parkinson's disease and depression. And if there's too much stimulation of the dopaminergic receptors, you can get, again, mania and schizophrenia. So norepinephrine and dopamine are very similar. Now, dopamine we use as a drug to increase blood pressure, but it also has central nervous system effects that are also stimulants. So you probably are more familiar with like alpha and beta receptors, but dopaminergic receptors are also all throughout the body, and they help with your blood pressure, but they also stimulate the central nervous system. The mania and the schizophrenia, when you have too much dopamine, you're stimulating the body, right? So just think like the person's like wicked amped up, okay? Now, serotonin, is that kind of happy, feel good, like, eat some dark chocolate and you're smiley. When you don't have enough serotonin, you get sad, so you should eat more dark chocolate. But if you get too much of it, like too much of a good thing is still too much of a good thing, and you start to get jittery and you get anxious, you get anxiety. And we'll talk more about like serotonin syndrome, and how people become like tachycardic and tachypnic and hyper-reflexive and hyperthermic even when they have too much serotonin, like when they're on multiple like serotonin and norepinephrine reuptake inhibitors, and it gets stuck in the synapse and won't stop firing, right? So serotonin will cause the anxiety, but not the mania and schizophrenia, because it just makes you feel kind of restless. And then histamine, if you don't have enough histamine in your body, you get depressed. If you have too much, you have anaphylaxis. Sorry, just being silly. Okay, GABA. So GABA is, when we talk about like alcoholism and we talk about drug addiction, GABA plays a big part in that. It slows down the body. When the GABA is decreased, you see things like Huntington's disease, anxiety, schizophrenia, and even seizure disorders, right? So GABA is a big one. So those are the neurotransmitters that I want you to look at, and maybe make flashcards or something so that you can look at the transmitter itself, and then increased and decreased, like how that's going to impact human behavior. Okay, so that's what I want you to know on the neurotransmitters, okay? Then we're going to flip over to the hormones, and the hormones are on page 60 and 61. Again, I'm going to go through the table, but I want you to read the little blurbs in the body of the text. So that actually starts back on page 59 under neuroendocrinology, and learn a little bit more about these as well. But things hopefully that you learned in LPN year, or at least heard of, like antidiuretic hormone. We just talked about oxytocin, which is good because it doesn't play too much of a role in psychology. But so look through these and say like, okay, which ones of these could impact psychology, right? So if you have an imbalance of ADH, you might have a problem with sleep. If you have an imbalance of growth hormone, you might develop anorexia nervosa, which is actually really interesting. The studies behind the causes of anorexia nervosa are actually pretty interesting. Thyroid stimulating hormone. Now, I'm going to spend a minute on this because the way that the book writes it is very confusing. So please make sure that you're writing this down. TSH, thyroid stimulating hormone. These are all of these hormones work on what's called a negative feedback loop, which means that there's something too low that causes this to be released, and then when it gets high enough, it gets shut off. Okay, so this is like a negative feedback loop, and these hormones are all mediators. Okay, so thyroid stimulating hormone is released in response to low thyroid levels, and it stimulates the thyroid gland to secrete additional T3 and T4. When your TSH level is high, that means that your body doesn't have enough T3 and T4 and you have hypothyroidism. Okay, so while your TSH level is high, your T3 and T4 are low in your bloodstream. Okay, and that might be confusing. If it is, just let me know. If your TSH levels are normal, then your T3, T4 levels should be normal as well. Okay. What happens on occasion is that you have like a pituitary tumor that will hypersecrete TSH. The way that this line for thyroid stimulating hormone is written does not make sense. I'm going to read through this the way it should actually be written. So the hormone is thyroid stimulating hormone. The location and stimulation of release, it is from the anterior pituitary. It's released by thyrotropin releasing hormone from the hypothalamus, which is again stimulated by low T3, T4. The TSH then targets the thyroid gland, which stimulates secretion of T3 and T4 for metabolism of food and regulation of temperature. Now, if there's too much T3 or T4, so if the person becomes hyperthyroid, you'll see insomnia, anxiety, and it should say emotional lability, not liability. It should just say emotional lability. If thyroid levels are decreased, you'll see fatigue and depression, but you'll also see an increased TSH. So I need you to make that connection mentally, that a decreased level of TSH won't cause anything. Increased level of TSH is related to a decreased thyroid level. So this line in your textbook did not do a good job explaining that correctly. So just next to decreased levels, fatigue, depression, put a little like up arrow like elevated TSH or something like that to remind you. And then it's decreased T3, T4 where it says increased levels, insomnia, anxiety, emotional lability, that's hyperthyroidism. So like Graves' disease or too much synthroid or medication, or even like thyroid tumor, something like that. Okay, so a thyroiditis, whatever. But increased levels, insomnia, anxiety, emotional lability are all hyperthyroidism, and decreased levels are fatigue and depression of thyroid, not of TSH. All right, I think I've beaten that to death, but hopefully you get that, because it drives me nuts the way the book is written. Let's see. ACTH, again, can affect mood disorders and psychosis. When it's increased, it can cause psychosis. When it's decreased, it can cause depression, apathy, and fatigue. And that has to do with cortisol. Prolactin we just covered. Gonadotropin. So gonadotropin hormone, those actually have been also related to anorexia nervosa, which is interesting. And we know that if you get too much testosterone, people can end up with sexual aggressiveness and physical aggressiveness as well. And then if you have a decrease in melatonin, you can end up with depression. Okay, so just again, look at those hormones and make sure that if you're confused on those hormones, ask me or look them up in a different book, because I think this one little section of this book is not the greatest. All right, circadian rhythms. So there's been a lot of hormones that impact our sleep and wake cycle, and they function everything from like seasonal affective disorder to premenstrual dysphoric disorder. So your book is talking about sleep and wake cycles. So there are basically like 6 different brain waves that you'll see on an EEG when you're sleeping. So first is stage 0, that's alpha, and that's when you're just relaxed, you're awake but your eyes are closed. Stage 1 is beta, so it's nice that they go A, B, and that is where you're kind of transitioning into sleep, you're kind of dozing off, your thoughts wander, you drift in and out. Stage 2 then becomes theta, and that is kind of like a light sleep. So half of your time is in sleep. Eye movement, muscular activity are minimal. Stage 3 is delta, and this is your deep and restful sleep. And stage 4, there's also a delta, and that's the deepest sleep. Okay. In stage 3 delta, your muscles are relaxed, your heart rate and blood pressure fall, your breathing slows, there's no eye movement at all, and the your brain waves are just very, very slow. And then in stage 4, you are at the lowest. Now what's interesting is that if you take sleep aids, you oftentimes don't reach stage 4, and stage 4 is really what you need for regeneration. And so people who suffer from insomnia and sleep disorders don't usually hit stage 4, that delta rhythm. And then REM sleep, or that beta rhythm, is coming back up again. And this is your dream cycle. And this is where you have that rapid eye movement sleep. And it's the brainwave pattern is similar to stage 1. So that's why they call it a beta rhythm again. And your heart and your respiration rates increase. Your blood pressure can change as well. And you might be able to be like, woken up at that point in time easier than like if you're in a stage 4. Okay. So things that can influence your circadian rhythms and your sleep, and your sleep definitely can also influence your circadian rhythms. So your circadian rhythms, which are also referred to as like your biological rhythms, can be impacted by like the manipulation of the light and dark cycle, travel or changing time zones, if you work the night shift or if you do different shift work, or any disruption in your sleep patterns that can really mess up your circadian rhythms. And your circadian rhythms kind of control everything. They control when you eat and drink, they control fluctuations in body temperature and hormone regulation and secretion. And it's basically like your brain has a pacemaker in it, just like your heart does. And when you mess that up in your brain, kind of everything gets messed up. And so people who work shift work or don't sleep normally, or sleep like days some days and nights other days, shown to like get sick more often and have more medical problems because the body can't regulate itself the way that it should. So most of our biological rhythms run on that 24-hour, like that circadian or biological clock. The only thing that doesn't is like women's like menstrual cycles or whatever, you know, they run over a month rather than a day. Thank goodness. And your mood also is impacted by the environment, your interpersonal factors, medications, hormones, things like that as well, just like your circadian rhythms are. All right. Alteration in brain function correlated to various psychiatric disorders. So this is on page 66 and 67. So they're looking at like schizophrenia might be related to, or is actually related to, dopamine and glutamate. Depression, norepinephrine, dopamine, serotonin. Bipolar disorder, norepinephrine, dopamine. Panic disorder, again, remember the limbic system and the midbrain, norepinephrine, and then decreased GABA. Anorexia nervosa, decreased epinephrine, serotonin, and dopamine, but then also possible, they said possible decreased levels of gonadotropins and growth hormone and increased levels of cortisol can cause anorexia nervosa as well. Obsessive compulsive disorders, which again, remember, related to anxiety, decreased levels of serotonin and increased cortisol levels as well. And then Alzheimer's disease, decreased acetylcholine, norepinephrine, serotonin, and somatostatin. So, you know, all of that, again, interesting correlations between physical manifestations and neurotransmitters that are kind of out of balance. Various diagnostic procedures used to detect psychiatric disorders. So these are on page 67 on to 68. So EEG is basically like an EKG, but we do it on the head, right? So the electrodes are placed on the scalp. And sometimes we try to induce a seizure. Sometimes we let people sleep. And sometimes, you know, we just have them in like a light wake state. There's computerized EEG mapping where we try to find different areas of the brain to see, you know, how they're functioning. CAT scans we can use as well. MRI, PET scans. So that would like a nuclear med study, and then the SPECT testing, which is just like a longer active radioactive. So just remember, like if your patient has a PET scan or a SPECT scan, that they're going to have a nuke med sign on their door, so no pregnant women in the room with them. Most places it's 48 hours, I believe. Analyze the effects of psychological and social factors of functioning on the immune system. Yes, I think I said that. So your mood is controlled by the environment, interpersonal factors, medications, hormones, things like that. Analyze the physiological effects of psychotropic drugs. You don't need to know these for the test. They're on 72 and 73. It's like a good introduction. Don't spend time on this. I'm not going to ask you any questions on this. And then discuss the implications of psychobiological concepts for the practice of psychiatric nursing. That's just on the bottom of 73, and then into 74, they're talking about the implications and the importance of psychiatric nurses having a knowledge of biological sciences, as well as neuroanatomy, neurophysiology, neuronal process, neuroendocrinology, circadian rhythms, genetic influences, psychoimmunology, psychopharmacology, and diagnostic technology. So they're talking about all the things that we just studied and how important it is that you understand the information that is in Chapter 4 in order to be able to provide good mental health nursing care. So flashcards for those charts, and that's what you're really going to focus on, right? So you're going to focus on some of those hormones, you're going to focus on some of those neurotransmitters, and you're going to look at, like the limbic system, where it is, what it does, circadian rhythms, sleep cycles. That's it. Just really simplify this chapter, because I know that these learning outcomes look ginormous. Okay, so Chapter 5 is a review of ethical and legal issues, and in this book, very specific to psychiatric nursing care, which is great because, for 2/3 of you, that's where you're headed tomorrow. So some things to think about. Vocab words. Ethics. Ethics is the study of what's right and what's wrong, based on societal norms. And then morals is what you feel you should do based on those same societal norms. And it could be a group or a culture, but morals is like something that you decide you should do based on the value system of a culture or a society as a whole, versus values themselves are very personal, and so those are your personal beliefs, and those could be in line with a religion or a culture or a group or a society, but the value system varies more person to person than the overall morals of a society. And then your rights are things that you are legally entitled to. And that's important to know, because you can't violate the rights of another person, right? If you violate someone's right, you've committed a tort, T-O-R-T, and that is a word that you should recognize in your nursing practice, because that, my dear friends, is what you get sued for. Okay, so let's talk about some ethical and legal issues in terms of nursing. So they talk about autonomy. Autonomy is the right of the patient who has capacity and who has competency to choose for themselves. So autonomy is huge. We talked about beneficence, which I always want to say wrong, but we talked about beneficence, and that is, you want to do good for other people, right? Again, that's an ethical issue. That your goal when you're at the outset should always be to do what is right for somebody else. And then according to Peplow, who is the mother of psychiatric nursing, she was like the original psychiatric nurse theorist, she also says that in terms of being beneficial to the patient, so being practicing with beneficence, that you should be an advocate. And I think that you guys all are. I think you recognize that. Non-maleficence then is the do no harm. It kind of goes with the Hippocratic Oath, like the above all else do no harm, but it's just saying that you should never intentionally or unintentionally do harm to someone. Justice is the principle of being fair, right? And veracity is to be truthful. So you have a duty to always be truthful. And if you're not familiar with that word, veracity, write that one down, because that is it is so illegal and unethical to lie to a patient. And that goes from any pediatric patient where you're about to give them a shot and you tell them, no, this isn't going to hurt, even though you know it is. And it goes all the way up to an elderly person where you're about to give them a medication and they say, what are you giving me? And you tell them the wrong med on purpose, or even unintentionally, but veracity is, on purpose. So healthcare providers should always tell the truth and should never intentionally deceive or mislead clients. And, that's huge, because in your practice, I bet you 50% of you in our class have seen someone operate dishonestly. And they think they're doing it for the benefit of the patient, and it is unethical. right? And then we're going to talk about sometimes when it's also illegal. So your book has a nice little model for medical ethical decision making on page 81, but basically just, make sure, is it the right thing to do? Is it in the best interest of the patient? Is it what the patient wants? And, if there's anything that feels icky about doing it, then you really shouldn't do it. Okay. Some other ethical issues. So again, going with autonomy, the patient has the right to refuse medication. And so just remember, like, if the patient doesn't want it, you can't give it to them unless there is a court order mandating that they have it, or unless you know for 100% certain that that patient has a healthcare proxy and does not have capacity or competency to refuse. So if I am working on a med-surg floor, or if I am working in long-term care, or if I am going to somebody's home, it doesn't matter what setting I'm in. If the person is competent in that very second to say to me, like, yeah, I really don't want that, it doesn't matter why they're supposed to take it or what they take it for. I can't give it to them. I can't make them take it. Okay. And so it doesn't matter like how badly you know that they need it. You can't make them take it, even if it's going to make them really sick or if they're going to die. And sometimes that's frustrating, right? You've got a patient who's up on, med-surg floor, and they really need their blood pressure medicine. They don't feel well. They don't feel like taking anything. And you know that they're going to get so sick if they don't take it, and they just don't want it, and you can't make them take it. Okay. So never ever give somebody medication that they say they don't want, unless you have a court order or you have a guardian who and the doctor in combination have said, yes, we're going to medicate either against their will or covertly. Or if the patient is an acute threat to self or others, like they are psychotic, you can't reason with them, they are violent, they are out of control, and you can't talk them down or get them to a safe place, then you can medicate them without permission from them, because you're doing it to protect them. The right to least restrictive treatment. Again, something that you should understand. If you have a person who wanders, you can't tie them to the bed because that's convenient for you. You can't lock them in their room because that's convenient for you. Instead, you either have a one-on-one or some sort of a wander guard or something, you do something where you lock the doors so they can't get out, or you put an ankle alarm on them or something. But, facilities have come up with great critical thinking ways to not physically restrain patients. So they have the right to the least restrictive treatment available that will still keep them safe. Okay, so those are just ethical issues that you should be aware of. Those are huge for us, because if you violate those, I guarantee you'll end up in front of the Vermont State Board of Nursing trying to defend your position. And I've worked with some fabulous nurses who have lost their nursing license for this. And they didn't do it intentionally. They thought they were doing the right thing for the patient by either like secluding them or by medicating them, and they ended up no longer able to practice, which is terrible because they were fabulous nurses. They just didn't understand these principles. All right, legal issues. You know that your scope of practice comes from your Nurse Practice Act. I'm not going to get too much into the types of law or civil versus criminal, but let's talk about a tort. So a tort is any violation of someone's right. Okay, and so if someone has a legal right to something, whatever that entitlement might be, and you violate that, then you can be sued or charges can be brought against you, or you could lose your license. So torts include things like assault and battery. They include libel and slander. They include false imprisonment. They include violation of HIPAA. They include failure to protect the rights of the patient to have informed consent. So there's a bunch of things that fall under what we call intentional torts. So things that you do intentionally, or by making a clear choice. And then there's unintentional torts, which hopefully some of you guys remember, and that's negligence. And negligence is also referred to as medical malpractice. And so I'll talk about that in a second. So let's go back and let's talk about some of these intentional torts. Okay, so the first one, assault. Assault is where you threaten somebody, right? So like think about like a verbal assault. Battery is where you whack them with a bat. Just put those two words together. So I'm verbally assaulting you, or I'm beating you with a bat, so I'm committing battery. So assault and battery. Assault is not hands-on, okay? Both put the fear of harm in someone, but only battery actually causes physical damage. They can both cause mental damage, but only battery actually causes physical damage. But you intend to do that when you do that. Libel and slander are defamation of character. Okay. When you commit slander, you talk about somebody in a way that harms them somehow, says bad things about them. Or when you commit libel, you write something. And that includes your documentation and your charting. So be really careful what you chart, because people like to read their medical records. And if you write something unfavorable about someone, they can come back and they can sue you. Okay. Now, if it's true, if you say that, like the patient was unkempt and they had a foul body odor, and that was relevant to your nursing notes, then that's okay. But if you're like, oh, this patient's a disaster, whatever, like don't put in your personal assessment of the patient. Just use facts, because they can't dispute the facts. So violation of informed consent is where you fail to ensure that the patient signed the informed consent forms prior to doing a procedure, or you failed to tell them the information, or you failed to tell them the risks and benefits, or you failed to give them their choices. So on page 87 in your book, they talk about there are some conditions where you can do treatment without informed consent. So somebody who's mentally incompetent, if there's an immediate threat to life or limb, during an emergency, if there's a child and you have to either get consent from a parent or a surrogate or save their life. Again, the threat to life or limb applies to children. Or what they talk about, case of therapeutic privilege, where the information about a treatment may be withheld if the physician can show that full disclosure would hinder or complicate the necessary treatment, cause severe psychological harm, or be so upsetting as to render a rational decision by the client impossible. Just to give you an example, like we had a patient who was raped, and they were repressing, so involuntary, repressing the memory of that event. And it was a younger girl. She was 14 or 15 years old. And it was fairly brutal. I think she was in the ICU for a couple weeks before she was discharged, and it was found out that she was pregnant. And so the parents decided that they couldn't make her keep this child because every day, first of all, she was so young that they didn't want to put her through that, but then every day that would be a reminder to her of this happening. And if I remember correctly, it was her brother's friend that did this. So they decided to terminate the pregnancy, and they didn't tell her, first of all, that she was pregnant, and secondly, they didn't tell her what was happening to her. They just took her in. They told her that she needed a checkup or something like that, and they ended up just putting her to sleep, taking her to the OR, doing a DNC under general anesthesia, waking her up in the pediatric area. And I believe that what they told her was that she had some sort of, I forget, tumor or growth or something like that in her uterus, and they had taken care of it. So they don't want to upset her. So that's just an example of sometimes when we wouldn't tell somebody, and that's called therapeutic privilege. Now those are few and far between. Like, we don't want to do that to people normally, but sometimes we do. Okay, so informed consent has to be given. You have to tell people why, and you have to give them autonomy, the right to refuse or to accept. Okay, as far as HIPAA goes, violation of somebody's confidentiality, again, is an intentional tort. And you should all know what protected health information is and what it is not. But just remember that it is not a violation of HIPAA to share relevant information with the team. And so this goes back to the veracity for a second and about being truthful. In the mental health field, we have patients, especially our borderline personality patients, who will try very hard to employ what we call splitting behaviors, where they'll try to make you their best friend, and they'll try to pit the team against each other, and they'll try to find like that one person who's going to be vulnerable to them, and kind of like pull them into their mess. And you know, they'll say things to you like, hey, can I tell you a secret? Like, you got to promise not to tell anybody. The answer is no. So you can tell me anything that you want to tell me. However, if it directly impacts your care or if the rest of the team needs to know, I legally have to tell. Okay, and that's what you have to tell people. Like, you can't promise to keep secrets, and you can't offer to keep secrets, and you can't become buddy-buddy with these people because they will just take advantage of you to no end. So the correct answer is, you are welcome to tell me anything, okay? However, if it is something that pertains to your care, I have to tell the rest of the healthcare team. And that's the honest answer. So back to that veracity, like, you have to be honest with people, because if you say to somebody like, no, oh yeah, absolutely, you can tell me anything, I promise I won't tell, and they're like, oh, I have a knife in my bag. Well, obviously you have to tell somebody, and then that person's going to be like, you promised you would keep my secret, you know, or whatever. Like, you know, obviously you can't keep a secret like that. So just make sure that you don't violate other HIPAA, right? So not talking about anything that's protected in open areas, not taking anything off of the floor that has patient information on it. And then in your book on page 86, they talk about the exception to HIPAA, which is a duty to warn, which is a protection of a third party. If a patient tells you that they're going to kill somebody else, you do have a right or a responsibility. So it says advanced practice psychiatric nurses who are licensed to practice independently would be held to the same guidelines as therapists. Just generally, you and I are not acting independently, so we would have to tell the physician. And that's not a breach, but obviously we'd feel terrible if we didn't tell somebody and they got hurt. So as far as restraints and seclusion go, don't do it unless you have an order or unless the person is immediately a threat to themselves or others. If somebody is restrained, they need an in-person evaluation by a physician, clinical psychologist, or other licensed independent practitioner within 1 hour of initiating the restraints or the seclusion. Okay. If somebody is simultaneously restrained and secluded, they have to be a one-on-one. So it's at all point in times they have to be watched, right? So when you take away somebody's rights, which are just their legal entitlements, like to breathe, to urinate, to defecate, to eat, to drink, to move, you become responsible then for all of those things, which means that you have to constantly have someone who has an eye on that person in case they vomit and they're on their back, or in case, you know, they need something, right? Someone has to take care of them. And so then the seclusion and the restraints have to be removed at the earliest point in time. Now, you as the nurse are responsible for putting eyes on that patient every 15 minutes while in restraints. And that's critical, because if you fail to do that, the Joint Commission is going to be all over you. So every 15 minutes, you have to have eyes on that patient, and that means, you know, not like in there stimulating them every 15 minutes or they're never going to calm down. You know, maybe just go in quietly, you know, say, how are you doing? Do you need anything? You know, okay, you know, so-and-so is still sitting with you. Just let them know if you need anything. I'm going to check back again. But really, you know, you have to have eyes on that patient very, very frequently, okay? Again, use the least restrictive restraint possible. and then get the doctor in there as soon as possible. If you don't, it's going to be considered false imprisonment, and false imprisonment is considered an intentional tort. So that's the deliberate and unauthorized confinement of a person within fixed limits by the use of verbal or physical means. So if you tell somebody, sit in that chair and don't move, that's technically false imprisonment if they do it. Okay, so don't do that. And if somebody is a voluntary admission and they want to leave the hospital, they're allowed to go. The only time we can keep them is if they're an involuntary admission and they're trying to leave. Then we can have, like, either don't unlock the doors or security bring them back or whatever, but don't ever yourself, don't try to physically like stop somebody from leaving, because you could get hurt, but you can just call the police or call security to bring them back if they're involuntary. But if they're voluntary, they can just go. I mean, they can sign out AMA. You can't hold them, even if you think that they're, depressed or whatever. If the doctor hasn't ruled them an immediate threat to self or others, and they're there voluntarily, they can go at any point in time. So make sure you read carefully through like the voluntary, involuntary commitment and emergency commitment that are on the very, very bottom of 88 and then on page 89, just because this is really important to your nursing practice, right? So involuntary hospitalization means that I can take you and I can lock you up without your consent. And you can be saying to me, I'm fine. Like, I was just having a bad day. I don't really want to hurt myself. I'm not going to hurt anybody else. Like, you can be so adamant about the fact that you're fine. And I can say, see you in 72 hours, like, this is huge. And when you do this, you can't do this alone. So the person who gets involuntary admission usually has to be independently assessed by 2 different providers. So usually there's 2 people who say, like, for an EE, the emergency commitment, usually we say 2 people have to assess that person to say, yes, we're going to hold you against your will. Okay. So every state's going to have slightly different rules. One of the big pitfalls that we run into is it's very hard to transfer someone across state lines if they're involuntary or emergency. So usually if they're involuntary or emergency, they have to stay within the state that they're being evaluated in. And so if we don't have beds in Vermont and the person's like from New York and has New York insurance, we can't get them back to New York. So even if they're from Troy and they want to go to Samaritan, if they show up at our hospital and they're risk to themselves, we can't get them back to Samaritan. It's really tough. Okay, so anytime that you've got somebody who is a danger to self or others, okay, unable to take care of themselves, so what they say, like, quote unquote gravely disabled, but meaning from a psychological standpoint, like those people would be involuntarily committed, right? It's not against the law to be like poor or to be homeless or to be dirty or to not take your meds. Like, none of that stuff is against the law in Vermont. But it is a cause for involuntary committal if you are homicidal or suicidal, or if you are psychotic, or if you are violent, or if you are just absolutely unable to care for yourself at all. Like if you were what we would like, mentally insane. And then if the mentally ill person is really in need of treatment and they're unable to make informed decisions about themselves, likely to cause harm to self or others, or unable to fill basic personal needs, then we might actually have to go to court to obtain guardianship of that person. So that's part of our, our legal issues. So it also then talks about some outpatient stuff. All right, so negligence. So let's go back to our unintentional torts for just a second. So we just covered a bunch of intentional torts. So just don't do any of that stuff we just talked about, right? Just practice all of those principles, like the ethical principles and the legal principles we talked about, and don't do any of that bad stuff. So negligence. In order to be guilty of negligence, all you have to do is either not do something, do the wrong thing at the wrong time, do the right thing at the wrong time, do the right thing and have it not work. Like, it doesn't matter, right? So people can just say like, hey, you know, I went to the hospital and I came out and now my knee is worse than it was before. I'm going to sue you for negligence. Oh, okay, great. So how does that like filter down to us? Because a lot of times nurses get implicated in negligence. So the first thing they have to say is you had a duty to act. Well, that's pretty easy to prove because either you had a responsibility to care for that patient or you didn't. No big deal, right? We have lots of duties. No big deal. 2, they have to prove that there was a breach of duty. And by breach, all they mean is that something happened that was outside of the norm. So whether you forgot to, you know, do all 5 rites of medication administration, or whether you administered a medication late, or whether you forgot to do a dressing change, or whether you didn't document something, like maybe you did everything absolutely perfectly, but you forgot to document something, technically that's a breach. So breach means that you didn't do it exactly the way that your peers would do it in an ideal world who are trained to the same level as you. Okay, so the care rendered was not consistent with the recognized standard of care in a textbook. 3, harm resulted. So the client was somehow either mentally or physically injured. So there was a duty to act, there was a breach of that duty by the nurse, there was some sort of harm that the patient suffered. All of these are pretty easy to prove, right? Or at least easy to claim. Like, you were my nurse, you didn't give me my oxycodone, I was in terrible pain. Okay, so 4. And this is what they have to prove beyond a shadow of a doubt. So you're innocent until proven guilty. The burden of proof is with the plaintiff, not with the defendant. So we don't have to prove anything. We just have to sit there and smile. This is called proximate cause. That's an A. Proximate cause. Okay, so proximate cause says that the harm was directly caused by the breach. And that's very difficult to prove. So let me give you an example. You're an ER nurse. A patient comes in from a car accident. They're intoxicated. They just wrecked their vehicle. They were ejected from the vehicle because they didn't have their seatbelt on. They come in and their Glasgow coma scale is low. Let's say it's like, you know, 9. We decide we're going to intubate. We intubate the patient. It's a very difficult intubation. We end up having to move the head more than normal. And the patient gets intubated. They get, you know, the helicopter comes, transfers them to Albany Med. At Albany Med, you know, it's found that they have a cervical neck fracture and they're paralyzed from the neck down, and they don't have any use of their arms and legs. So did we have a duty to act? Absolutely. Was there a breach of duty? So, well, sometimes that's questionable, right? But did we have to move the head more than normal? We did. Did harm result to the patient? Sure, they're paralyzed. Did we cause that? So now they have to prove beyond a shadow of a doubt that there's no way that that paralysis would have happened from that injury alone, from being ejected from the vehicle. And that's really hard to do because there's going to be plenty of docs who are going to take that stand and say, hey, you know what? Cord swelling doesn't show up for, you know, X number of hours. It's 100% like that fracture was there already. It's 100% possible that that intubation had nothing to do with that paralysis. Right? Same thing's going to happen to you. You know, somebody's going to say, like, you know, you started an IV and I got an infection from it. You know, I didn't see you scrub the hub, whatever. You're going to say, I remember scrubbing the hub. Then they're going to go back and they're going to look at infection rates and they're going to say, you know, oh, 14% of people with IVs get infections. They're going to say, you caused my infection. And you're going to say, prove it. Prove it was me. Right? And they're going to have to prove that that one time that, you know, they can't remember you scrubbing the hub actually happened and that it was you. And that's really hard to do because, you know, again, nurses are the most trusted profession on the planet. And if you sit up there and you say, like, you know, I absolutely did that and I did it the right way, and you have other people who are vouch for you that, you know, what you did was along the lines of what they would have done, negligence is very hard to prove. So gross negligence, like if you kill somebody, or if you decide that, you know, you're bored and you just want to do a C-section on your own, like, you know, that would be easy to prove. but just regular negligence is harder to prove. So things that commonly psychiatric nurses get sued for: breach of confidentiality. So again, don't violate HIPAA. Defamation of character. So don't commit libel or slander. Don't commit assault or battery. Don't threaten to harm your patient, or don't try to coerce them as well. So that's bad. Invasion of privacy. So that goes along with HIPAA as well. Don't look into medical records that you don't have any reason to be in there on, or don't ask somebody like, oh, why is that person here, right? So when I'm having like my mental breakdown, don't all of you come in and say, what's Inga in for now? It's stress. I'll just tell you right now, it's stress. To avoid liability, on page 91, it says you should always respond to the patient when they ask for help. You should educate the patient as much as you can. You should always comply with the standard of care. You should supervise any care that you delegate, and that's really important. Just remember that at all times, like no matter what you delegate, you remain responsible for. Always adhere to the nursing process. Document carefully, and follow up by evaluating the care that was given. And just really remember that some clients are going to just threaten to sue you no matter what you do. So a natural response by you is going to be to withdraw from them, or to get really defensive, or to think of reasons why you don't like them. You know, like you're going to employ some of those ego defense mechanisms, and they're going to be maladaptive. So just don't do that. So no matter how bad the patient is acting, just try to deal with the client's complaints. You know, be as professional as you possibly can, and think about their emotional needs. So really just sit and listen to them and try to take care of them the best that you can. And that is, that's really huge. Okay, so that's what I have for chapter 5. I know this is super, super long, and I hope that this helps you.